All right, welcome back. I'm Professor Adam Thompson, and this is a video on bleeding and shock. We're going to talk about bleeding and shock in this video. All right, so let's talk about shock. Shock can result from many different conditions, including bleeding, respiratory failure, acute allergic reactions, or even an overwhelming infection, right? We have many different types of shocks, many different causes of shock. Hypovolemic shock, all right? This is shock from inadequate blood volume. Inadequate blood volume, and the volume can be lost as a result of blood, plasma, electrolyte solution. Hemorrhagic shock is the most common cause of shock. All shocks. Hemorrhagic shock is the most common cause. But remember, hypovolemic shock could be either hemorrhagic or it could be due to dehydration, loss of electrolytes. All of these things can cause a hypovolemic shock. It's often due to blunt or penetrating injuries to the vessels or organs, long bone or pelvic fractures, major vascular injuries, such as a traumatic amputation can cause hemorrhagic shock. And then, of course, your multi-system injury. It could be both external or internal or both. Organs and organ systems with high incidence of exsanguinations from penetrating injuries include the heart, right? Obviously, if there's a stab wound or a bullet wound, gunshot wound to the heart, you can have a pretty quick exsanguination and death. Thoracic vascular injuries or the thoracic vascular system, anything that penetrates that, of course, is going to be very similar to an injury to the heart. Abdominal vascular system, there's a lot of problems with injuries, especially penetrating injuries to the abdomen. Of course, hemorrhage is one of them, but then the sepsis that follows is also a huge problem with injuries to the abdomen as well. And then your venous system and your liver. Your liver can bleed pretty well. Remember, the ligament of teres can cause a lacerated liver. It's a very common injury, especially in rapid deceleration, motor vehicle accidents. Hypovolemic shock caused by hemorrhagic trauma is classified by the American College of Surgeons Committee on Trauma in 4 classes, which are compensated shock, classes 1 and 2. Decompensated shock would be class 3, and then irreversible shock, which is class 4. And if you look at this table here, you could see normal circulation versus compensated shock versus decompensated or hypotensive shock. Some of the basic changes, you can go from clear consciousness all the way to a restless patient, combative. They could be unresponsive, any type of altered mental status. We know that somebody will go from a brisk capillary refill to prolonged to basically no capillary refill or mottled skin. All of these things happen. You have a normal heart rate, becomes tachycardic, and then eventually bradycardic, and then eventually, a heart rate of 0 if they continue on with no change in their shock state, or no treatment stopping the shock, I should say. So estimated fluid loss and blood loss for a 154-pound patient, which happens to be exactly 70 kilograms. All right, so if you look, these are your classes of hemorrhagic shock, okay? All right, so class 1, it would be less than 750 milliliters of blood loss, which is less than 15% of their blood volume. And you're not going to have too many changes. You're going to have a blood pressure probably within normal limits, heart rate. It might be a little elevated, mostly normal. Respiratory rate's going to be on the higher end of normal. They could be a little anxious. They're nice and pink. They might be a little cool because remember, blood loss, blood's where we get our warmth. So, of course, they could cool down a little bit. With about less than 15%. Now, when you get to 15 to 30%, that's your 750 to 1,500 milliliters of blood loss. Now you're going to see a mild tachycardia, 100 to 120. You're going to maybe see a minimal or no change in their systolic blood pressure, but you'll have a narrowing of your pulse pressure. That means that your systolic blood pressure and your diastolic blood pressure are getting closer together. All right, capillary refill may be delayed, probably not going to be delayed. Your respiratory rate, it's a little bit faster than normal, but hard to pick up. Whoops. All right. They could become a little bit anxious at this point. They're definitely going to start getting a little bit diaphoretic, clammy skin, that kind of thing. Where you're not paying too much attention to urine output if you don't have a Foley catheter in. But you're going to want to start fluid replacement with these patients. Class 3, all right? That's 1.5 to 2 liters of blood loss, all right? This is going to be 30 to 40%. This is going to be a pretty fast pulse, faster than 120. They're going to have a significant drop in their systolic blood pressure. And then it's also going to be a narrow pulse pressure, but now their diastolic might actually start to come down. Capillary refill will be delayed. They'll have markedly elevated respiration because whenever somebody goes into shock, they want to start breathing faster just because they're not getting enough oxygen where it needs to go. They're going to be anxious and confused. They may be completely altered. At this stage, they could be lethargic, cold, pale, moist, diminished urine output, of course, and crystalloids. If you have blood, whole blood's great. Class 4. Remember, this is your irreversible shock, okay? Greater than 2 liters of blood loss, which is 40%. It's over 40% of their blood, their total blood volume. And then they're going to have a marked tachycardia until they don't, right? Of course, it's going to last as long as it can. Significant depression in that blood pressure, a very, very narrow pulse pressures with delayed capillary refill, markedly elevated respirations, confused, lethargic until they're unresponsive, cold, pale. They might not be diaphoretic anymore. And then minimal or no urine output. And of course, you want to give them fluids and blood if you have it. The initial stages are characterized by that low circulating blood volume, minimal signs of hypoperfusion, all right? Where the body begins to compensate, patients begin to have tachycardia, hypotension, and signs of poor tissue perfusion. As oxygen supply to the tissues is compensated and cellular metabolism is altered, patients become more confused and anxious. And the compensatory mechanisms continue to increase systemic vascular resistance, which is leaving the patients with a cold, mottled, and pulseless extremity and worsening mental state. All right. Remember, whenever you have an increase in systemic vascular resistance and a decrease in overall perfusion, you're going to have that narrowing pulse pressure. And that's why we were seeing that with those upper stages of shock. And then if they're left untreated, shock will progress to the decompensated stage, which means that they're going to die, right? If you don't do some sort of intervention, these patients left untreated will, go ahead and exsanguinate and die. Compensated versus decompensated shock. Just kind of a basic table that gives you an understanding of the difference. All right, so your patient that's agitated with some anxiety and some restlessness, that's a compensated patient. Somebody that's got altered mental status is decompensated. They may be maintaining a blood pressure on the compensated side, whereas you're going to have marked hypotension on your decompensated side. They could have a sense of impending doom on the compensated side. However, that you could see anywhere with a patient that's going to die on you. A weak, rapid, thready pulse, of course. You might not feel any pulse with a decompensated patient or only central pulses. Clammy, cool, moist skin. Ashen, mottled, or cyanotic skin for the decompensated shock patient. Shortness of breath, of course, for both sides, really. Diminished urine output, of course, for both sides, but a lot more for the decompensated patient. And then delayed capillary refill, especially in your infants and children on your compensated side. You may have no capillary refill when they become decompensated. So all of these things you take into play. The big one, I think, is the mental state. All right. If somebody has an altered mental state or is lethargic or unresponsive due to hypovolemia or hemorrhagic shock, that's a decompensated patient. That's a really sick patient. Along with, of course, taking the full clinical picture, your vital signs, your skin signs, all of that stuff. And that helps you kind of decide where they are on the spectrum. When it comes to management of these patients, it is going to rely on how far along they are with the bleeding. You don't want to rapidly infuse fluids on all of these bleeding patients because of something we want to have called a permissive hypotension. When you rapidly infuse crystalloids, you're not giving them blood, so you're not giving them clotting factor. You're causing a dilution within that blood. You're diluting the clotting factor, which can cause a problem with their hemostasis and their clotting. So you want to make sure that you're providing the right amount of fluid to maintain perfusion to the vital organs without causing more coagulopathy. Remember to keep these patients warm because of that trauma triad of death, and try to differentiate and know how far along they are in that class of hemorrhagic shock. Are they that close to an irreversible or decompensated shock? Because all of these patients really are going to require rapid management and treatment, and potentially surgical intervention. And it's about giving the right amount of treatment up to that point. And with that, that ends this